So the American STD Association's mission is to foster scientific knowledge, develop leadership, and champion practice in the field of sexually transmitted infections. We have many ways that we go about doing this. Again, I would encourage you to visit our website for more information. But one of our objectives is to recognize outstanding contributions in STI control and prevention. So each year we give out a number of awards designed to help recognize people that have made significant contributions. And finally, the most coveted award that the ASTDA provides every year is the Distinguished Career Award. And this is presented to a person with a long and extraordinary career in the field of sexually transmitted infections. And this year's award winner, very appropriately, is Dr. Gail Bolan. Gail received her undergraduate training at Goucher College in Maryland, her medical education at Dartmouth, and her residency training at the University of Virginia. Prior to attending medical school, Gail worked as a chemist at National Institutes of Health National Cancer Institute. Gail also had fellowship training at the CDC's Epidemiologic Intelligence Service, Tufts, and Stanford. And for the last 33 years, Gail has worked at local, state, and national public health agencies with a focus on STI control. In January of 2021, Gail will be stepping down from the position of Director for the Division of STD Prevention at the CDC, which she has held since 2011. She has made large and sustained contributions to the field of STI, HIV, and sexual health during her nearly 40-year career. Having worked at the local, state, and federal levels, Dr. Bolan has leveraged her unique perspectives to modernize STI and HIV prevention, both locally and nationally. And she has led with commitment and passion to help move our field forward. So thank you so much for your service, Gail. I'm terribly pleased that this can go to you because I think that, especially in this era of understanding epidemiology as well as diagnostics, as well as medical care, you bring everything to the field that we need right this minute. Thank you so much for all of your contribution and your commitment to our field.
Congratulations, Mom.
Thank you very much, Sarah. Good morning or afternoon, depending on your time zone. First, let me begin by thanking ASTDA. I am both honored and humbled by this 2020 Distinguished Career Award. My career has been spent trying to bridge science and policy and program, making programs more evidence-based and science and policy more programmatically relevant. As you will hear today, there is still much to be done. I must also give a special thanks to Kyle Bernstein and Laura Bachman, who secretly submitted the ASTDA nomination paperwork. I was completely unaware of their submission and had to do some good old-fashioned DIS investigating to find out who was responsible for my nomination. Next, I'm thankful for Bobby's kind and delightful introduction. Bobby's been a great colleague, and I'm pleased to receive the award from her during her tenure as president of ASTDA. Finally, I'm so grateful for Lynn Barkley, the CEO of ASHA. She was the force of nature behind this event. She and Bobby came up with the tribute idea, and Lynn has worked tirelessly putting this together. I even hear she's become best friends with my husband, who needs all the tech help he can get, and has retaped his segment 3 times because of wardrobe malfunctions. To everyone who shared a tribute message, I would like to thank each of you for your collective appreciation, humor, and stories. Today, I've been asked to reflect on my work and how I came to do what I'm doing. As for the latter, the answer is simple: serendipity. As for the former, I prefer to reflect on our work as a journey. We all know it takes a village to prevent STDs, and that STD work is a team sport. My career path began with academic medicine and bench research, but in 1982, I took a fellowship with CDC's Epidemic Intelligence Service that changed everything. The supportive and collaborative public health culture, the goals of using data for public health action and impacting population health, and a Group C strep outbreak in New Mexico, where Dr. Jonathan Mann, then the state epidemiologist, who told me, quote, "I have no idea why you would consider working at CDC after EIS. Don't you know all the action is at the local level? Feds can't even work in a state without an invitation." It altered my career trajectory. It also didn't hurt that I met my life partner, Art, at CDC, who calls himself Mr. Bolan and likes to think he saved me from myself. In 1987, after completing my EIS fellowship in infectious disease training, Art and I were living in San Francisco and Oakland. At the same time, the San Francisco Department of Public Health STD director position was the only public health position opened in the Bay Area. I was completely unqualified for the position by most standards, never had seen a case of syphilis, never had cared for a transgender person, had no STD publications, and the only sexual health question I was taught in medical school was, have you ever had any problems with impotence? But the person hiring must have been a bit nuts and selected me for the position anyway. So my journey in the field of STDs began. As director, I quickly learned the incredible value of public health and academic partnerships that are mutually beneficial if true collaborations are established. And I encourage all of you to explore these types of partnerships in your jurisdictions if available. In the early 1990s, we transformed City Clinic into a center of STD HIV excellence, which continues to deliver high quality comprehensive clinical care while also providing sexual health training to medical and nursing students and residents and conducting programmatically relevant STD research. We integrated hepatitis B vaccination, pap smears, intimate partner violence and substance use screening services, started the Thursday morning clinic, an appointment-based clinic for HIV care and family planning services, and dabbled in billing for services. Julie Schachter may deny he said this, but he encouraged me when I arrived in San Francisco to pursue bacterial vaginosis research because, quote, no one at UCSF was working in that area. My response, I told him my job was to prevent STDs and that I would focus on diseases where the natural history and effective prevention interventions were known, and I was happy to work with him on chlamydia. I am grateful for years of academic collaborations with many of you, and I'm not sure what I would be doing now if I had followed his BV advice. My journey continued moving from the local to the state public health in 1997 when I joined the California Department of Public Health STD branch. After more than a decade with the state, I returned to CDC in 2011 as the director of the Division of STD Prevention. When I interviewed with Dr. Kevin Fenton, he asked me, why have you only had 2 jobs in your career? It never struck me that having only 2 jobs wasn't the norm for a future director, but I realized in my response to him that I had chosen my journey on my terms and not what others thought I should do. My answer was that I was a builder more than a climber and wanted to make sure I was home for my family before all were grown. Well, clearly he hired me anyway, and that is how I came to CDC. Successes for me were not tied solely to work, but also measured by a work-life balance, thanks to Art. A few of you may remember when I brought Sarah to the first PI meeting of Bob Rawls' syphilis study, the first randomized controlled trial of syphilis in the post-antibiotic era, as my husband was on a trip. Sarah was 3 months old and didn't take a bottle, which resulted in a few shocked PIs as I breastfed during the meeting. At the annual PI meetings after that, I would always mark the passage of time by how old Sarah was. Sarah was in 5th grade when this landmark syphilis study was finally published in the New England Journal in 1997. Though I must admit, I'm now a bit more forgiving about CDC timelines since coming to CDC to work. As I reflect on my time in STDs over these past 30 years, I'm struck both by the progress made and the challenges that are still left in the field. As many of you know all too well, STDs have surged for the 5th consecutive year in 2018, reaching an all-time high, and it looks like this trend is continuing in 2019. Nationally, over 2.5 million cases of chlamydia, gonorrhea, and syphilis were reported to CDC in 2018. STDs can impact anyone, yet the disparities deepen for the most vulnerable groups. Youth, ages 15 to 24, have long accounted for most reportable chlamydia and gonorrhea infections, and now are experiencing syphilis increases too. The disparities among gay, bisexual, and other men who have sex with men is stark. MSM make up the majority of syphilis cases. In 2018, 1 out of every 282 MSM was diagnosed with primary or secondary syphilis. This was 122 times the rate among men who have sex with women. Pregnant women face some of the harshest outcomes from untreated STDs, as underscored by the continued rise in congenital syphilis. In fact, a recent CDC analysis found that in 2018, 1 in 2 newborn syphilis cases in the United States occurred due to gaps in testing and treatment during prenatal care. Commonly missed opportunities to prevent congenital syphilis also differed by region, illustrating the importance of tailoring prevention solutions to this most tragic consequence of the growing syphilis epidemic. If rising syphilis cases were not enough, the threat of untreatable gonorrhea is alive and well. Gonorrhea has dramatically increased since 2013, the first time since the 70s, and it can't be explained solely by increases in screening. However, while gonorrhea cases are increasing, no cases of antibiotic-resistant gonorrhea have been found in the United States. With the downturn in the economy in the late 2000s, erosion of state and local public health infrastructure began to occur. STD specialty clinics, settings known for serving MSM and other populations seeking confidential STD care services, closed, and a number of public health staff decreased, resulting in reduced availability of same-day treatment for individuals with STDs, particularly infectious syphilis. Furthermore, fewer patients and partners were linked to care and treatment. The crippled infrastructure has not yet recovered and is still a factor contributing to less timely detection and treatment of cases leading to further transmission in the community. After the AIDS epidemic in late 1980s and early 1990s, syphilis began to rise among gay, bisexual, and other MSM in the early 2000s, when the availability of life-saving medications had an impact on sexual activity and sexual norms. Several years later, in 2012, the development of PrEP, which requires routine STD screening, altered the game of STD prevention and control, again by providing additional opportunities to detect and treat STDs. While opportunities for screening with PrEP have increased, the ability to locate partners has become more challenging. The use of the internet and geosocial networking apps for meeting sexual partners has exploded in recent years. These apps eliminate geographic limitations and make it easier for individuals to connect with and meet new people. In 2016, almost 50% of individuals with early syphilis in San Francisco reported using geosocial networking apps to meet partners. This is a dramatic departure from the bars and bathhouses where partners met previously. It's interesting that the approaches to syphilis prevention and control in particular have not changed much in almost 100 years. In Surgeon General Dr. Thomas Perrin's Shadow on the Land, published in 1937, he outlined a syphilis control approach that is akin to the most recent syphilis elimination efforts. First, he highlighted the need for a government role in the prevention and control of a private social disease, while others argued at the time that sexual activity is a voluntary activity where individuals should take responsibility for his or her actions. HIV is a clear example as to how the role of government intervention improves the social well-being of a society. Second, Dr. Perrin provided a platform for action, recognizing that there were still many unsolved scientific answers about syphilis, but felt the diagnostic and treatment tools of the time were good enough. Often in public health, we have to proceed with good enough and not wait for the perfect scientific answer. These principles are still applicable today for the STD field, though advancements are underway. Within the next 6 months, the first ever federal STI strategic plan and a state of the state of STI National Academies of Science, Engineering, and Medicine report are planned for release. These plans and strategies are essential, but not completely sufficient. The what is important, but the how and the implementation are more so. As I said, to reverse these trends, it cannot be done by one sector. It's going to take a village, including partnerships between federal government, health departments, academia, healthcare providers and systems, community-based organizations and communities, industry, policymakers, and more. More science and innovation is needed to inform program interventions of high impact in areas of population composition and social determinants of health, network dynamics and behaviors, and technologies, so the healthiest choice is the easiest choice. COVID-19 has exposed what many in the field of STD have known surrounding the limits and weaknesses of our society's infrastructure and safety nets that include, at the basic level, community trust and trained staff. Consequently, alternate models to increase access to timely testing and treatment, such as express visits, testing outside the healthcare setting in pharmacies and homes, and growing telemedicine models are needed more than ever. Our innovations need to be holistic. We must examine not only the disease itself, but how the disease occurs in the context of patients' lives, ensuring linkages for co-occurring conditions, and offering integrated comprehensive care at the client level. We live in a world with rapidly changing technologies, and we need to keep pace with the world around us and take advantage of opportunities. By investing in a comprehensive health equity approach and recognizing the power of communities, the need for culturally sensitive healthcare facilities, and the importance of trust in community leaders, STD trends can be reversed. Few fields of medicine are more dynamic and diverse than that of the field of STDs. The focus has moved from the individual patient to their lives and their communities, from individual bugs to the communities of organisms in the microbiome, and from siloed, limited data systems to large volume data clouds with unlimited variety and velocity in data science. That is why STDs is an extraordinary and professionally rewarding field if you like diversity and challenges. We may be under-resourced, but we make up for that in ingenuity, resilience, innovation, perseverance, and the ability to adapt quickly when change is needed. But we cannot do this without a new generation of STD leaders and champions in the field. I'd like to leave you with this. STDs are a societal problem, a collective responsibility, and a measure of our nation's health. And I would not be where I am today without many colleagues, mentors, staff, patients, and family who have taught me everything I know. Too many to list, but have to thank the staff in San Francisco, the California Department of Public Health and CDC, patients at City Clinic, colleagues in the STD family and beyond, and lastly, my growing nuclear family, Art, Becca, Sarah, Brett, Jake, Eric, Jacob, and Danny, who make me laugh every day. Thank you.